Dr. Pizzo couldn't be with us today, but Dr. John Samet, who's Dean of the Colorado School of Public Health, was gracious enough to step in. He is joined by Dr. David Lambert, who's a professor of medicine and senior associate dean for medical education at the University of Rochester. Dr. Shireen Mark, who is a staff physician at Cardiology Consultants of Philadelphia. And Dr. O.J. Saylor, who is professor of pediatrics, psychiatry, health humanities, and bioethics and oncology here at the University of Rochester. Dr. Samet, I hand it over to you to begin the future of medical education discussion.
Okay, great. Thanks, and welcome everybody to this session. We're going to cover a lot of topics, and our goal is to, I think, hopefully set the stage for a conversation on a topic that we are all interested in, the future of medical education. I think for those of us who graduated long ago, we know that some things have changed and some haven't, and I think there's a maintained common purpose and tradition. So with those remarks, I'm going to turn to my colleague to my right, O.J. Saylor. I will say parenthetically that in 1963, I walked into my first chemistry class at Harvard and shared a balance with her in quantitative analysis.
I did not do well in the course.
I tried to help her.
Didn't work.
But with that, I'm going to turn and actually my first question to her, and she's going to talk about medical schools and who should be coming in, is looking at the two of us now, or some of us, what would be different in terms of what's looked for in a medical school applicant and a prospective physician?
Okay, so I took that particular question to heart, and I had some ideas, and I should tell you this is based on 17 years of being clerkship director here in pediatrics, and having met lots of people who were aspiring to be physicians. And so I had some ideas, but what I did was I went to, as it turns out, 11 people, and they ranged all the way from a medical student to a physician who's even older than we are, and to people who are outside of medicine, and asked them the following question. Without thinking about it for more than 30 seconds, what are 3 qualities that you think a medical school applicant should have to practice now and in the future? And fortunately, my assistant knows how to do a cloud. And so here's the cloud, and I'll tell you in a moment what it says. But it was really, I think, fascinating and reminded us that there are some qualities that I think are transcend time. And the very first quality, biggest, was curious. That the person who is applying should be curious, interested in what's going on, not only in medicine, but in the world at large. So, and also sort of within that area were things like lifelong learner. So curiosity, as I thought about that, I thought, maybe somebody was going to say, oh, we don't need to know about antibiotics anymore, but we all need to know about immune therapy. Or maybe we all should be looking for people who are going to be doing brain mapping and using technology much more sophisticated than our current fMRIs, for example. But it wasn't that specific. What it was generally people who are interested. When you think about it, no matter what's coming down the pike, people who are curious will be able to, I think, get into the groove without missing a step. 2 other things, just slightly below curious, were the person perseveres, that there are going to be times when it's going to be very difficult to do the job of being a healthcare provider and a physician, but that person looks beyond today and perseveres into the future. And also along with perseveres was the word empathetic. And I think that as we think about ourselves now, all of the unrest, the issue of inequalities, prejudices, they've been with us forever. They've been with us forever. This is not new. But are we teaching our students to be empathetic? Are we suggesting to them that they really think about the person who is in front of them? George Engel would say yes. As a third-year student, I had I wasn't sure whether it was a blessing or a curse of having Dr. Engel as my, small group interview instructor, which, was very scary. But the notion of looking at the person and looking at all aspects of that person, I think is what empathetic comes down to. Communicator, and we were talking a little bit about can physicians do effective telemedicine? And one of the next qualities was that that person be a good communicator, that person be able to use language that is appropriate when talking to a peer, and language which is different and geared toward the understanding and the situation of the person that they are talking to as a patient, as a family member, so that they understand the implications of the health status of the person that they're talking about. Also at exactly the same level is the issue of being open-minded. I think that goes along with our issue of curious and persevering and being empathetic, that we are open-minded to new ideas and that we are open-minded to the situations that people are facing when they come before us for our advice and our administration. And last was the word compassionate on the same level as communicator and open-minded. And I thought about compassionate, and I thought, is compassion just for some people? Some of you may know that I've spent my entire career working with chronic and terminally ill kids. I've been palliative care service. And so compassion, I think people say, yes, okay, well, obviously you should have compassion. But I want to just tell you that I learned compassion during the third year at RGH when I was on the cardiovascular service. At that time, single bypass surgery had a mortality rate of 50%, 60%. And I was privy to be at the surgery of a 34-year-old man whose wife was pregnant with their third child. He did well, surgery until about 2 hours after surgery. And then he coded. And the code went on for maybe about 10 or 15 minutes. And then the surgeon said, call his wife. Keep doing the resuscitation. Call his wife. And he got on the phone and he said, Mrs. Jones, I just want to let you know your husband's not doing well. As you know, he did well the first couple of hours. But I'd really like to talk with you. And I wondered if you could come in. And he said, now I know you're pregnant. Is there someone who could come with you? Oh, your mother. Okay, have your mother come. It's very busy up here in the recovery area and surgery. And I think it would make the most sense if we could sit someplace quiet, just so we won't be bothered by a whole bunch of other people. And he sort of thought for a moment and he said, let's meet in a chapel. And so I was sitting there and I said, can I go with you? And he said, no. So I tried a second time and I said, can I go with you? No. And then I said to him, if you don't teach me, who will? And he said, all right, You sit in a corner and you don't say a word. And we went down into the chapel and he pulled out a chair for himself and he pulled out a chair for me right next to him. And he told the woman that at this point, because after he got off the phone, he said, let's call the code. And so he was alive when when he made that call, but had died by the time she arrived. And he went through some comments about how her husband had done well, then had a problem. They wouldn't know right now exactly what went wrong. And she just sort of stopped and she blurted out, I can't cry. And he said, you will. You will. You are in shock. And no one questions whether you loved your husband. We all know that you loved him deeply. But right now, you are in shock. So what I want to ask you to do is I want you to come to my office in a week. Wednesday afternoon, maybe, early afternoon, okay? Yes. And we will talk about your husband. And I'll have more information. I'll be able to tell you about what went well with the surgery, what didn't go well with the surgery, but we will talk. And over the years, I've thought about that. And my sense is that what he was saying to her was, you will get through this week. You will get through this week. And I will be there to talk about your husband and call him by name. Also, in the intervening years, what I have really, really rued is, why was I there and not his resident? Because the resident really needed to learn that aspect of the skill of this physician. And so I can share that story with you today, but unfortunately his resident can't. So yeah.
Great. Thank you for telling us that story. We're going to go on to Dr. Mark Shireen, who's going to talk about healthcare disparities. I would say in introducing her and the topic, our students are expecting a lot from us right now around healthcare disparities and addressing structural racism within our institutions and externally. So this topic is one that has long been with us. It didn't resurface with the pandemic. It's been there. We weren't paying enough attention. It wasn't there. It was there before George Floyd, and we weren't paying enough attention. So let me turn things to you, Shireen.
Right. So on my drive here, we are listening to a podcast, and the former Pepsi Cola CEO, Indra Nooyi, had made the statement, you have to understand why people do what they do before you can make changes in their life. And that really resonated with me because I kind of was asked here to discuss what I wish I would have learned in medical school to prepare me in my training in regards to health disparity. And Rochester does a great job through the biopsychosocial model, preparing us for that one statement she made, you have to understand why people do what they do. I remember in PBL classes going through cases. One was about a young woman, let's say, with sickle cell. And you had to understand why she wouldn't take a blood transfusion because she was Jehovah's Witness. Okay, inherently that group of people are Black, right? And so that was one of the PBL cases that we had. Rochester is very selective in who they choose to make their student body, and our student body was diverse. And so there were a lot of ideas and thoughts that came around in that PBL class because you had a diverse group of students. So I think it's important in healthcare education, making a diverse student body and really highlighting, we'll get the bio, but you have to understand the psychosocial. And you get that through experience and through your peers and through your teachers. What I did not get out of here that did not help me, I would say, is pharmacoequity, the costs of medicine. Inherently, medicine is inequitable because of cost. I still don't understand how I get paid. I don't understand the cost of the services I provide my patients. I don't understand why one insurance company will say, yes, they can get their PET CT, and this one has to do a treadmill stress test when I know their PET CT is the best test for my patient. Or I have to do a 24-hour halter first before I can do a 7 or 14-day movie. You know, I'm involved in a little research project now with my organization where I have to ask patients, kind of get to the core of what they understand about their condition and what their biggest fear is. And it's always, how am I going to afford my medical care? How can you make my drug more affordable? And I can't help my patients there. And so I think we need to apply a form of healthcare economics in our curriculum so that the doctors could better be versed in educating our patients ourselves about, you know, how patients are going to afford their diagnostic treatment and their medicine. So we can prescribe all the medicine in the world, but if they can't afford it, they're not going to take it. So I think that would be what's lacking, and that would help improve health equity, health disparities, is leveling the playing field for cost.
Thank you.
Mhm.
Okay, great. I've have the public health mantle. I have to say, Jack, you said much of what I wanted to say, that there's medicine here and public health here is creating a divide that there shouldn't be. And hopefully in reality, there is not. And at least the ideas of managed care have brought the notion of populations and population health into sort of the parlance of medicine. I think in sort of giving obeisance to the biopsychosocial model, we were taught the importance of understanding who people are, what the populations are, where they come from. My days in 16 years in New Mexico taught me that I couldn't treat a patient from Tierra Amarilla without understanding the populations who live there, or from the South Valley of Albuquerque. And while I was at UNM, and still going on there and elsewhere, was efforts that were pioneering at the time to try and bring notions of population into the day-to-day teaching. I have to say with varying success, because there are barriers there to be broken down. Having lived in the two worlds, run a clinical division, run schools of public health, I think we do need to bring them together more, and that's a challenge. And you know, we've heard some of the barriers around financing, the time limitations, but our nonprofits are charged with addressing the health of the populations they serve, and they're supposed to be understanding and monitoring that health and spending money on finding out about the health of the populations they serve. So I think these are worlds that hopefully will begin to come together in greater ways. I think I've also been asked to sort of take on the challenge of how do we make a difference? And I think healthcare disparities and the resulting health inequities are critical. I can show you 50 years, I can show you more years than that of research, some done by actuarialists originally, Louis Dublin, for example, who long ago showed that being poor affected health and longevity. Coke McCord published a paper in the New England Journal in the late 70s that showed the equivalent lifespan for males in Bangladesh and Black males in Harlem, and those differences persist. Those stacks of papers have not yet made a difference, and we know that the choke point here is political, and that somehow we need to bridge that gap. There are other gaps that we can bridge, and again, I think public health has given me the opportunity to try and step into that translational space, which some others in medicine do. We do that through our professional societies. We do that in evolving guidelines. We do that by bringing our voice into different committees and places. And I think we can make a difference. I think it's critical for medical students, for all students actually, to have faculty who are willing to step in and bridge these gaps and have role models. I think those of us who are in the classes of 70 and 71 probably have these opportunities now where people come to us and say, gee, how did your career happen? It's hard to explain because these things sort of unfold. Ira talked about the influence of Vietnam. There was a wave of people who came into public health at that time because they were in public health service as an alternative to being in the military. Our class, 1970, was the last actually to be subject to the draft. I don't know, I was drafted. Was anybody else here actually
Oh, I wasn't
drafted?
drafted, I just joined.
Yeah, so, and did it impact our lives? Absolutely. We made career paths, took career directions because of our experiences in those years. And I think, again, what I learned out from my time sort of sitting in the Army and stepping out of the easy lockstep of sort of, medical school, internship, residency, practice, and reunions, it was a jolt. And I said, well, what do I really want to do? And I think at that time stepped into this sort of translational space of trying to do things that will impact public health. So I think we need to continue to have people who do that. I think Rochester, with this long tradition of thinking about populations, needs its role models. And there are some here, of course, and elsewhere, who are doing that kind of work. So I think, that start in the biopsychosocial model is important. I'm sort of amused when people come to me with their very complicated diagram about what influences the health of somebody down here and has a whole bunch of stuff getting down to that individual. Well, that's what we were taught. And it's still there and still true. So with that, let me turn to David. And our goal here, again, is to tee up for a discussion who is going to address current education and perhaps where we're going.
Oh, great. Thank you for that, and welcome everyone. It's good to see people back and to see some people who I touched upon a few years ago directly. So in reflecting on the conversation, is the future of medical education, it's a combination of what do you continue to do, what do you preserve, and what do you change? And so for this particular school, we've heard a lot about the biopsychosocial model, which is still a foundation of the medical student education program here and will continue to be, along with clinical acumen and basic science knowledge and the things that we would expect of any medical school. But as societies change, we need to incorporate other pieces of information into medical education. And so the curriculum here, being specific, is some of the things that we've integrated is health system science, which is a series of topics that the origin of the term health system science came from Susan Skoschlak and others from the AMA, but it's incorporating things such as social determinants of health, such as population health, teams. How do you work in teams? How do you function in teams? Which we have a lot of other things that we do for that as well. Patient quality and safety. So students are learning about patient quality and safety as early as the beginning of the second year when they can apply it to ambulatory settings that they've been in along the way. Issues around disparities in healthcare. We lead off with discussions of that in the first week and bring someone in who talks about redlining in Rochester so people can understand what is the impact of that on the community in which they are here. What is the impact of it over time, and what are some potential ways to overcome those things as well? Within the medical program as well, we talk about what are the core things that every student needs to have, and I could go on talking about a four-year curriculum. I could take 4 years, but we don't have that much time. But then we also have to think about what should a medical school offer to enrich the medical education experience. And so we have a lot of different ways that we do that, but some of the buckets or areas that we do are research. We are a research-intensive institution. We have a lot of opportunities for students to do research, whether it's through a summer program or year out, or helping them to secure national funding for year out. That's an important part of medical education for those who are interested in that. That's not that's not for everyone. Our volunteer and community service opportunities are a big part of who we are, how we define ourselves. You know, I lose track of time, but in the 20, maybe 27, we earned a national award for community service. And our students have free clinics, not a term that everybody embraces, but you understand what I mean for this purpose, as well as other things that intersect with pediatric populations and others. And the third one is international, is that we are part of a global community, a global population. We talk about population health, population of our community here and of the world, and our students are now beginning to go back to a variety of different places around the globe to learn and to provide care as well. Then within that, and I'm going to be brief because I really prefer the questions and direct questions. I think we have cards and other things for that, is those are sort of three buckets, but then we have a variety of different pathways that we've established here that have made us unique. One is a medical education pathway, where students can get experience in didactics about how do you teach, how do you become a medical educator if that's a long-term plan that you have. We have a large deaf community. We have a deaf health pathway, a Latino health pathway, a global health pathway, and more recently, a pathway where students help to affect policy, run by Kate Cerulli. It is incredibly dynamic, where in the end of the 4 years, this is an elective experience, they will go to Washington with her and meet with politicians and understand how do you become an agent of change. We have that in the curriculum as well, but if you're really interested in that, how can we support you along the way? And I get asked a lot of times when I meet wonderful alumni like you and others is, what kind of student do you graduate? You know, you graduate people who are researchers, I said, we graduate excellent students. And we give them the opportunity to do whatever they want and to be successful in wherever they want to be. So I mean, I'm going to stop there if that's okay, just because I think the questions are an important part of the session, if that's all right with you.
That's great. We've been a very good panel, leaving a lot of time. Let me start off. Oh, yeah, well, thanks. Let me start off a question for you, for OJ, for anybody. I worry, having interacted with pre-med students a lot over the last decades, that in fact, the grueling track of being a pre-medical student and all that goes with it, in fact, starts to remove curiosity, starts to remove some of the attributes we want people coming in, because it's such a grind to write the essay, take the MCATs, and whatever else. When I relate the fact that when I took the MCATs, it never occurred to me to study. And the night before I took them, the all-night bridge game in the dorm was going on. And I'd come out every now and said, we got shut up. I'm taking some test tomorrow.
I'd forgotten I was late.
She was late. But what do you think about sort of today's students rolling up? I know there's many
So
extraordinary.
they are very accomplished, and I am
Yeah.
very honest in saying I probably would not get into the medical school I got into if I was applying now. You know what I mean? If you took my cred and put it in front of them, they'd be like, don't even interview this guy. But I think that's the importance of a holistic evaluation, so that we don't just evaluate people based on numbers. Certainly you have to have a certain skill set. Let's face it, you want your doctor to be able to have a certain, understanding of science coming into it. But that's where we have 20 to 30 people who review applications and read all of them. If they make that criteria, to understand who is that person. And as I've said to students in the transition in COVID, we brought students back. Students came for orientation. And I got to tell you, I have PTSD over that, all of that. And we also were the first school in New York to bring students back to clinical. I have to throw that in, okay? And thanks to Mark and the fact that we are one system, we were able to do that. But they said, why do I have to come? I said, because we are a school about people. And you are people. And we need to establish your community immediately. Despite the restrictions, this is who we are. And sort of was, if you want to defer and think on that, you can. And everybody came and they really did understand the importance of that. Sorry.
I was one of the people who answered the question, what quality should a medical school applicant have? It was a young woman who's not at this medical school, who talked about the fact that her essay, the first time she applied, was what she thought the admissions committee wanted to hear. Did not get into any of the medical schools she applied to. same MCATs, whatever, the next year she said, I guess I'm just gonna tell them who I am. And she got into all 5 medical schools that she applied to. So I think you're exactly right. And it is a grind, but you have to remain a person throughout all of that and let that shine through.
I think the grind is important, honestly, because it doesn't go away. You know, you
Mhm.
still have to research for your exams every 10 years. There's still CME and there's still patient care. So if you're not all up all night, you know, studying for a test, you are, you know, closing out your charts. And so you have to be prepared for that life of intense learning, you know, over and over again. So the grind's important because it
Mhm.
doesn't end in our career.
I agree with you wholeheartedly. It's when you do things because you think that will get you into medical
Oh, yes.
school, as opposed to doing things that you want to do and that have
Right.
meaning for you.
Right.
So I think that part.
Correct.
is
And
the
that's the
issue.
beauty of Rochester, right? Because I did apply twice. I took the MCAT twice, but Dr. Hansen and everyone else here saw me,
Uh-huh.
you know, and gave me that opportunity. From Rochester, I went to Cornell for my internal medicine residency. From there, I went to UPenn for my cardiology fellowship.
Mhm.
But I was given the chance and scholarship to come here and excel. And so, you know, when you talk about health equity, some of it starts from here, right? From Rochester. And looking through all these papers and realizing it's not just a test score, you know, it's not just the essay, it's the whole person.
It's the whole
And
person.
who do we
exactly.
want in our seats to teach that are going to be able to foster better medicine in the
Yeah.
future? And so I think, you know, I'm sitting on this panel, Rochester changed my life because it saw me and saw that there was something I could offer. And so, you know, I love this place.
So this might be a good time. I think this is a comment and a reminder, the Morgan and Engel book we used, Clinical Approach to the Patient. I still have my copy. The qualities of the ideal physician as first and foremost, the ideal physician is first and foremost humane. To treat the patient as an abstract disease is to fail as an able physician. This encompasses many of the qualities Dr. Saylor nicely highlighted. So a nice reminder. Comment?
Do I still have my copy?
Do you?
Oh, I thumb it every night.
Okay.
But I only get through 2 pages, which is my usual sleep time.
Well, I think it was a good reminder. So this comment perhaps for David, for OJ, the U of R med curriculum include medical economics, public health, telemedicine. The comment goes by with that we had none. Actually, we did have, for those who remember, we did have epidemiology that Dave Rush taught for the class of 70. And we did have biostatistics
Which I
taught
passed.
by, which you
Right.
passed, taught by Charlie, Charlie Oderoff. So we did have both, and we actually had an epidemiology book and a biostatistics book, but update us on, I think, these broader topics that fit into the context of the prior discussion actually with Jack and Mark.
Okay, so we have a course that occurs at the Thanksgiving to December break called Medical Evidence and Inquiry that incorporates epidemiology and biostatistics and also brings that in with social determinants of health as well to understand how that data leads to us knowing other information and how we can interact or make changes. And then those concepts are reinforced throughout later in the curriculum. The telehealth piece, we were one of the earlier schools to incorporate that. I was fortunately able to be on a AAMC panel that set the competencies for telehealth across the continuum of providers. And so we introduced telehealth early on after they've had experience with personal interaction, because you don't want to go right to telehealth. And we did use telehealth during COVID, but to understand some of the aspects of telehealth that include looking at the camera, the things that to some people seem very basic, but to others are not, and how you interact and what you can do and what parts of an exam you actually can do in telehealth along the way. But then also the other part about the economics part. In other words, telehealth is great for someone in the rural environment. Do they have internet? Do they have a device? Do they know how to use it? Can they pay for it? All those other aspects along the way. And then we do some standardized patient encounters that are telehealth, and did a pilot with students in the psychiatry clerkship with nurses, interprofessional education, going out to discharge adults discharged from inpatient psychiatry to their homes to assess that transition using telehealth with experts on the other end along the way. So those are some, I think I touched upon a few of the things that you said there as well. And the health economics part is trying to understand, I'm looking at you because you brought it up. It's not your fault, but it is the way it is. Trying to understand the complexities of funding of healthcare in the United States.
I forgot who coined the term here. It's all in the HPI. I will never forget that from Rochester. I don't remember what professor said that, but that prepared me for telehealth. I mean, it is all in the HPI. Especially with we're not master clinicians at bedside exam anymore. Especially in cardiology, I have echo, I have my stress test, I have all these tools available. I mean, there's plenty of things you can get on a physical exam, but the majority of what's going on with the patient, they're telling you. I met a patient on a telehealth video visit, and the first time I saw her was after her cabbage. That's when I met her in the hospital. That was through the COVID pandemic, because my practice went full telemedicine for 3 months. We only saw patients in the office that really needed to be seen. And so, I was prepared for that through my education here, not knowing I would need to use it, but really getting a good history is just crucial.
I became a pediatric intern at Duke. And during I don't know, probably my 3rd week of internship, I was on the unit. And so I had written up a new patient. And one of the attendings came over and looked at me and he says, "Is this your write-up?" Yes. He said, "Oh yeah, you're the intern from Rochester." I wasn't sure whether it was good or bad, but I chose not to ask.
So I want to interject because I want to share another story. Is I'm fortunate to know people in medical education, other institutions. I was at a meeting, and the woman who was in charge of at that time was in charge of medical education at Duke. Her grandchild was born with esophageal atresia and was in a unit. And she said she was in there, and the intern came in and got down on her knees so that she was eye to eye for her sitting, and asked, after taking care of the child, "What could we do for you? Is there anything that we could be doing for you?" And I don't have to tell you where the student went to school, but she told me, I said, "Where did you go to medical school?" And she said, "Rochester." So it's been a couple of years since your experience in this one.
Right.
But
Well, I am
yours.
delighted to know that it's still happening. Because sometimes you wonder, having been here in the age of Engel and Romano and all of them, it's really good to know that it's still happening, and that our reputation continues.
Right, so continuing this line, I think the question broadly I'll construe is interprofessional education, which of course is a topic that we talk about a lot these days. And the question is a specific, but more generally, the question is, how do we train medical students to make use of a more diverse treatment team, like, for example, working with a hospital chaplain in the case of the blood transfusion of Jehovah's Witness. I'll actually comment parenthetically, but when I was drafted, on the strength of my straight medicine internship, the Army said you will do anesthesia. And my last case was a Jehovah's Witness with a GI bleed, sort of every anesthesiologist nightmare. And my comment to the patient was, "I'm going to give you a little anesthesia, not much. Raise your hand if you're having pain." In any case, this is the interprofessional question, I think.
Sure.
And what are we doing in that space? I think one that fits well with both of you.
Sure.
Well, I just want to say, we were here in Rochester back in the day, one of the very, very first institutions where the medical school and the nursing school got together around the issue of where do we fit as a team? How do we communicate? So that's been, I think, on the plate of here for at least 40, 50 years, with a real commitment to how do we talk to one another? How do we respect one another? And I'm hoping that's still continuing too.
Right, so we have a big piece of interprofessional education. It's required for accreditation, but it's important for practice. And in addition to having students understand the fundamental roles of individuals within a healthcare team, some of the things that we do is when we teaching about team dynamics, that's done jointly with the School of Nursing. Under Dean Rideout, we've had a lot of collaboration that's really been very exciting for us. In the latter part of the first year, there's a 2-day module called Addressing Disparities in Healthcare. You can understand what it's about. It's very interesting, and I don't have enough time to tell you all about it. But with that, we partner with social work students from Brockport, as well as nursing students to talk about, we have a standardized family and how do you navigate the family dynamics and the needs of everyone, and how do you meet them. And then we also do a number of things with the pharmacy students from St. John Fisher. We do them both in person and virtually with them because they have a whole virtual program as well. And then later on in the third year, there's a session where students reunite with nursing students, maybe not the same ones, in smaller groups. And they talk about, they go over a surgical and a medical patient quality case. But then what they do is in a safe environment, they discuss, what did you see when you were on these rotations? What things did you see that you think could have been better, to discuss? Because sometimes it's not a good place to process that. And how does your role and my role and their role, how did that interact? So there are a lot of things that we're doing with IPE that's, it's really a very, very important part of the curriculum. And you can tell the curriculum gets pretty crowded because anytime you add, you should subtract, otherwise no one will ever graduate. But we do I think we do a very good job of that.
I think going with that and maybe perhaps building a little bit on some of the comments that Jack Rowe made, there's a comment here about sort of a future in which primary care is increasingly handled by advanced nurse practitioners, perhaps physician assistants. And I guess it's a comment, but perhaps there's a question here about sort of teaching in the clinical sector to prepare for this changing environment, what may come. And, again, perhaps going back to you, David, or Shireen, from your experience in practice, how do you think we prepare our students for this new world that's likely to come?
Yeah, I think that's a tough question. I mean, I work with, we have about 6 nurse practitioners in our office right now. It started off as 2 when I began, and now we've added on an additional 4, looking for another. They're easier to hire. It takes us a longer time to get a non-invasive cardiologist in our area, and there's a significant demand with 2 hospital systems closing down. They're easier to hire, but a little harder to train, especially if they're coming out of training immediately. So they may not have the full breadth of cardiology under their belt, so we have to train them. But it's a reality. Because it's easier to get them, honestly, than it is to get MDs. And so I think we just have to learn, we can't fight it, it's here, and we're gonna have to learn to work with it. So I think as physicians, we are gonna have to be willing and able to train and work alongside and get them up to where they need to be for patient safety and for equitable care and for good quality care. We have to teach them what we know so that they can continue to perform amongst us.
And so from the medical student curriculum perspective, students are in primary care offices in the second year, where there are often PAs and nurse practitioners there, so they understand and get to see role models of interaction. And then one of the IPE experiences I talked about, the one in the third year, often brings in PAs and nurse practitioners into that to understand their roles in different inpatient settings and where responsibilities lie or don't lie, as well as on pretty much all of our clinical rotations. They will interact with a variety of different providers along the way.
I think we're running out of time, but I actually have a question left that's answerable by somebody. What is the cost of a year's tuition? And
It's going to be me.
yeah, you're on the spot. Mark's out there, you can ask him. And let's see, how much is tuition is guaranteed free of debt? Or what is the debt as students leave? So throw out some numbers for us.
So I was not, as my wife would say, psychologically prepared when I bring up ideas. I wasn't psychologically prepared for that. I don't have the exact numbers. Tuition's probably around 63,000. I don't know if any of you have kids in college. I have my last one in college, and when I got the email about the tuition, her college tuition is more than medical school, but I won't digress too much on that. Approximately a significant proportion of our students are eligible for financial aid of some form. 45% plus get some form of scholarship. The average debt for a medical student in graduating is around 180,000 from our medical school, which is slightly below that for the average for private medical schools. We've done well for a while because our financial aid director had gotten some competitive Department of Ed grants that were a few administrations ago that were timed and expired. And we're working very hard, and Mark and others, we met just, I think it was yesterday, the day before, to talk about how we can leverage resources to increase the number of scholarships for students, to maintain the diversity and to provide a very holistic approach to continue to be able to do that, to let those who we want to come here be able to come here. So that is, if you say what are the things that are the biggest challenges, that's right up there. And it's every other medical school has, well, not every other medical school, because there are a number of medical schools, as you know, that are tuition free. That movement has taken hold.
Yeah,
in order to become tuition free, you really need it, and it's done with an endowment. And roughly speaking, the numbers are pretty clear. If you have, for your 50,000 a year, you need an endowment of about $1 million. So for our school, if we wanted to make tuition free, we need a endowment of about 450 million. That was earmarked for scholarship. Right now, just while we have an endowment that's about 800 million, it's virtually all restricted departments, mostly for research. Our endowment, in order to for as specifically for scholarship, is about 25 million. So that's the daunting task. I think that if you ask any of us, anything, we'd love to have medical school.
Well, I would just say when the CMO and when you provided when we went tuition free, all I did was answer to the nursing students, thank you, to our surgical technicians, why wasn't their education free? So I spent more time dodging questions from other parts of the workforce who didn't like me before, really didn't like me then. And it was right about $475 million now, all earmarked for medical school students, but there's always the haves and the have-nots.
Yeah, John, I think, as was commented, there are a number of schools have become tuition free, have been some for quite some time. One in Southern California, another one in Ohio, et cetera, named and recognized. I think the critical issue that's driving this is student debt and the feeling that the oppressive effects of the student debt are driving students into specialties which are more remunerative and give them a pathway to pay out down the debt. Maybe those are not the specialties that are in most need. I think, having been president of a medical school 12 years, I think it's really important to distinguish tuition-free from debt-free. Because there are about 20% of the students who can afford to pay the tuition. Okay, if my daughter went to medical school, she couldn't afford the tuition. And so by giving that person a full scholarship, unless you hope and get lucky that they're going to donate, the parents will donate to the school and you can tell them it's tax deductible and with better strategy than tuition, that generally that doesn't work. So what you're doing is foregoing the money you would get from the 20% that you could use for scholarship, so that you can be tuition free. So there's a difference. Columbia has gone debt free. You pay what you can, we pay the rest. And there are a number of schools that are doing that as well. And if you add the tuition free schools and the debt free schools, I think you start to get to maybe 20 to 15% of the schools.
Okay, I think we're getting, we're not the signal, but this has been a great discussion. I think that tuition in the 60s may have been around $6,000, $7,000, I suspected. Does anybody remember?
What was it?
But how much, John?
I don't know what you guys paid.
5,076.
Yeah, but it wasn't 5,000 in 1966. Graduated in 25. It was 2,000. I think it was 2,000 because I was able to marry. And that changed.
Thanks, thanks, everybody. It's been a terrific discussion.